Semaglutide entered the American vocabulary sometime around 2022, though the compound itself had been sitting in diabetes clinics for years before anyone outside of endocrinology paid attention to it. It was approved for type 2 diabetes in 2017 under the name Ozempic. The weight loss was a side effect, noticed by doctors who kept hearing the same thing from their patients. Their appetite had changed, not suppressed exactly, quieted. Food stopped being loud. The mechanism is a peptide mimicking glucagon-like peptide 1, a hormone the gut releases after eating, one of dozens the body uses to manage digestion, blood sugar, and satiety. Semaglutide binds to the same receptors that hormone binds to, but it lingers. The natural hormone breaks down in minutes. Semaglutide, modified to resist that breakdown, stays active for about a week, which is why the injection is weekly instead of daily. It slows how fast the stomach empties. It signals the brain, specifically the hypothalamus, that the body has had enough. It also nudges the pancreas to release insulin only when blood sugar is high, which is the property that made it a diabetes drug in the first place. The clinical trials that got it approved for weight loss, the STEP trials, run between 2018 and 2021, showed participants losing around 15% of their body weight over 68 weeks, compared to about 2.5% on placebo. Those numbers are real, and they are large by the standards of anything that came before them. Phentermine, the most common weight loss drug of the previous 3 decades, produced average losses in the 5 to 10% range, and it came with the kind of cardiovascular caution that follows a stimulant. This is the part of the story most coverage stops at. Big result, few footnotes, cut to the B-roll of a doctor's office. The footnotes are where this account is going to spend most of its time, not because the drug is a fraud or a conspiracy, but because the parts of the trial data that get repeated the least are the parts that determine what actually happens to a person's body over the full course of treatment and after it. Start with what the weight loss is made of. Weight is not one substance. A body losing 15% of its mass is losing water, glycogen, fat, and lean tissue all at once, in proportions that depend on diet, activity, and how the weight comes off. Studies using DEXA scanning, which can separate fat mass from lean mass in a way a bathroom scale cannot, have found that on semaglutide, somewhere between 25 and 40% of the weight lost is lean mass. Muscle, mostly, along with some bone density. For comparison, weight lost through diet and exercise alone typically runs closer to 20 to 30% lean mass, and weight lost through bariatric surgery tends to land in a similar range to the drug. The number itself is not alarming on its own. Some lean mass loss accompanies almost any significant weight loss in almost any method. What matters is the mechanism behind it on this particular drug, because semaglutide does not just reduce how much a person eats. It reduces how much they want to eat, which in practice means many people on the drug simply eat less of everything, including protein, without any specific effort to preserve muscle. A study out of Wake Forest, presented in 2023, followed older adults on semaglutide and found that without resistance training or a deliberate high-protein intake, the lean mass loss was substantial enough that researchers began recommending strength training be built into every treatment protocol, not offered as an optional add-on. Nobody is saying this on the drug's marketing materials. The marketing materials show a number on a scale going down. The number on a scale does not know the difference between a pound of fat and a pound of muscle, and for a while neither did most of the people taking the drug. Muscle loss connects to something else the trials tracked less closely than the headline weight number. What happens when people stop? The Step 4 trial specifically tested this. Participants took semaglutide for 20 weeks, then were split into 2 groups. One continued the drug, one switched to placebo, both for another 48 weeks. The group that stayed on semaglutide kept losing weight, an additional 7% or so. The group that stopped regained on average about 2/3 of the weight they had lost during the initial 20 weeks. Not all of it, most of it. This is where a drug that is often discussed in the language of a fix starts to look more like the language of a treatment, in the way insulin is a treatment or blood pressure medication is a treatment. Something a body needs continuously to maintain an effect, not something that resets the body's baseline and then can be set aside. The appetite-quieting effect of semaglutide appears to be tied to the drug being present in the system. Remove the drug, and for most people, the hunger signaling returns to something close to where it started. That is not a hidden fact. It is published, peer-reviewed, publicly available. It is also not the fact that gets repeated in the parts of this conversation that live outside of medical journals, where the drug tends to get discussed either as miraculous or as dangerous, with very little room in between for what it actually is, which is a long-term intervention with a long-term commitment attached to it, financially and physiologically both. The financial part deserves its own sentence because it shapes the physiological part. At list price, semaglutide for weight loss runs close to $1,300 a month in the United States without insurance coverage. And insurance coverage for weight loss indications specifically, as opposed to diabetes, has been inconsistent enough that a meaningful number of patients start the drug, see the appetite effect, and then stop when the coverage lapses or the savings card expires. Whether the regain that follows counts as a side effect of the drug or a side effect of the American insurance system is a question this account is not going to resolve, but it is worth naming, because much of what looks like the drug not working long-term in casual conversation is actually the story of access, not biology. The side effects that are discussed most often are gastrointestinal, and they are common enough that most clinical trial participants experienced at least one. Nausea leads the list, followed by diarrhea, constipation, and vomiting, generally concentrated in the first weeks after a dose increase, since the standard protocol titrates the dose upward slowly over 1 to 4 months specifically to reduce this. Most of these effects diminish with time. In the STEP trials, gastrointestinal side effects were the leading cause of discontinuation, but they only accounted for roughly 4 to 5% of participants stopping the drug entirely, which tells you these effects are common but for most people not severe enough to outweigh the results. Less common but more serious is a cluster of effects around the gallbladder. Rapid weight loss of any kind increases the risk of gallstones, and semaglutide trials showed a modestly elevated rate of gallbladder-related events compared to placebo, somewhere in the range of 1.5 to 2 times higher, though the absolute numbers remain small. There is also pancreatitis, inflammation of the pancreas, which shows up at a low but real rate and led to an early caution in the drug's labeling, though later, larger studies have not shown as strong a signal as the initial concern suggested. The side effect that generated the most attention outside of medical circles was the one nicknamed, somewhat unfortunately, Ozempic face. It is not a distinct medical condition. It is the visible result of rapid fat loss in a part of the body, the face, that carries fat differently than most people expect, and where volume loss shows up quickly as hollowing, skin laxity, and an aged appearance that can register before the rest of the body has visibly changed. It is not unique to semaglutide. It happens with any fast, significant weight loss, and it happened long before this class of drug existed, to people who lost weight through surgery, illness, or extreme dieting. The drug simply produced this outcome in a large enough population, fast enough, for the pattern to become visible and nameable in a short window of time, which is part of why an entire cosmetic industry, filler, threads, facelifts marketed specifically to GLP-1 patients, grew up around it within about 2 years. There is a psychological dimension to this drug that researchers are still working through, and it involves more than appetite. GLP-1 receptors exist not just in the gut and pancreas, but in regions of the brain associated with reward, including areas tied to dopamine signaling. Some patients on semaglutide report a reduction not just in food cravings, but in cravings more broadly, alcohol in particular, along with a general dulling of what researchers sometimes call food noise, the constant low-level mental chatter about what to eat next. Early observational data and a handful of small trials suggest a genuine reduction in alcohol consumption among people on GLP-1 medications, enough that several pharmaceutical companies are now running formal trials for alcohol use disorder using this same drug class. Whether this represents a therapeutic breakthrough or an under-examined shift in brain chemistry with effects still being mapped is, again, a live question rather than a settled one. None of this is presented here to frighten anyone away from a medication that has, for a great many people, produced meaningful and durable improvements in weight, blood sugar, cardiovascular risk markers, and quality of life. The SELECT trial, published in 2023, showed a 20% reduction in major cardiovascular events among overweight or obese patients with existing heart disease, a result substantial enough on its own to justify the drug's growing use independent of the weight loss numbers entirely. This is a real medication with real, well-documented benefit. What gets lost is the texture of the trade-off, a drug that requires continuous use to maintain its effect, that costs more per year than many mortgage payments, that can quietly take muscle along with fat if nothing is done to counteract it, and that reaches into reward pathways in ways researchers are still mapping, is not the same story as the one usually told in a 30-second before and after clip. It is a more complicated story, and complicated stories tend to survive longer than simple ones, because eventually the simple version runs into a fact it cannot explain.